Hello, today we're discussing management of obesity with particular focus on GLP-1 antagonists. In a previous discussion, we had talked about pathophysiology of obesity, how obesity should be considered as a chronic disease. Abdominal obesity causes visceral fat accumulation. This increases free fatty acid and insulin resistance, impaired glucose uptake. There is neuroinflammation, brain fog. There's oxidative stress and inflammation causing mitochondrial dysfunction, leading to hormonal imbalance, increasing fat storage, and metabolic dysfunction, causing fatigue and hyperglycemia. Now, when we go into GLP-1 medications, they do not address all of these issues. They do work on the brain portion by acting on the arcuate nucleus and affecting satiety. Some of them work on the gut by decreasing gastric emptying. And the third target is, of course, the pancreas with glucose-dependent insulin secretion and suppression of glucagon. Now, currently we essentially use semaglutide or tirzepatide. Semaglutide in weekly subcutaneous 2.4 milligram injections. It's a selective GLP-1 receptor antagonist. Tirzepatide, weekly subcutaneous up to 15 milligram injections. Synergistically also works on GIP mechanisms, and dual antagonists are superior due to inhibition of food noise and improved adipose tissue function. Comparing to surgical outcomes, weight loss surgery results in 27.5% weight loss, whereas tirzepatide is 20 to 22%, semaglutide is 15 to 17%, and lifestyle alone is around 5%. Now, surgery has been shown to produce 80% remission of diabetes with about 8 years free from diabetes. The kind of surgery also makes a difference. These data such long-term data do not exist for the GLP-1 drugs. Beyond weight loss, there's definite improvement in cardiovascular mortality, and there's reduction in MACE by up to 20% in the SELECT trial. More recent studies have shown that this effect goes beyond just weight loss benefits. There's hemodynamic improvement in systolic blood pressure reduction by 5 to 6 millimeters. There's improvement in liver steatosis, such as MASH. There's improvement in lipids and LDL profiles. So this definitely goes beyond weight benefit. Now, with regards to obesity, we should consider it more as chronic care rather than cure. Obesity pharmacotherapy should be continued beyond reaching weight loss goals. Discontinuation results in recurrence. For example, we treat hypertension indefinitely, we treat hyperlipidemia indefinitely. Similarly, we should think about treating obesity indefinitely. Now, what happens if we discontinue the GLP-1s? When we discontinue GLP-1s and switch to placebo, there's a 2 to 4 times increased weight gain compared to those people who were on placebo. It's an average monthly regain rate of 0.4 kilograms, significantly worse than people that were on diet exercise alone. Now, basically, the regain drivers are endogenous GLP-1 that was suppressed, is no longer suppressed, hunger rebounds, and there's increased intake of food. Now, basically, real-world data suggests variability. Some patients do maintain weight loss 18 months post-cessation. Lifestyle changes is the window of opportunity. When obese people lose weight, then getting them on a proper lifestyle would help a lot. The safety profile of these medications, Pancreatitis is rare. Gallbladder disease is rare. Gastroparesis, there's a boxed warning about thyroid C cell tumors. The management strategy is to start low and go slow. Now, this often results in what we call skinny fat. There is significant rapid weight loss with fat loss and lean muscle loss, and the baseline muscle volume is decreased. There's increased risk of frailty and reduced basal metabolic rate. Now, you can mitigate this by adding resistance training. This is a non-negotiable adjunctive therapy. This signals muscle retention and reprograms the metabolism of the body. There should be high protein intake, target 0.8 to 1.6 kilogram per body weight per day. It is critical for preventing catabolism, particularly in elderly patients. The clinical management is to start low and go slow. For example, semaglutide, you start at 0.25, on the second month go to 0.5, etc. The optimal dose is not always a maximal dose, but is a maximal tolerated dose. Tirzepatide follows similar 2.5 milligram increments. In type 2 diabetics or obese, prioritize GLP-1 over other drugs, discontinue sulfonylureas. Type 1 diabetics, it's off-label use. There's a high risk of hypoglycemia, and you should reduce bolus insulin dosage by 10 to 20%. Monitoring of ketones is mandatory. Now, basically, you should not just do pharmacotherapy, but in addition to lifestyle intervention with increased protein intake, resistance training, proper sleep hygiene, this leads to sustained health. Now, often people have to discontinue due to cost or side effects. We should taper the dose gradually over 9 weeks if possible. We should bridge and switch to other oral agents that are approved for obesity management, and then surveil the patients for monthly weight and protein management. Now, there's a public health and equity access crisis. There's a high cost barrier with high out-of-pocket costs, and the economic impact of obesity is around $3 trillion annually. Now, we are not doing this for cosmetics, we're doing this for medical necessity. The next generation therapeutics are already arriving. Their oral formulations and triple antagonists are on the way. Muscle preservation is important. Anti-myostatin therapies are also on their way. These are designed to block muscle loss during rapid weight reduction. Here's a list of FDA-approved medications going from orlistat, phentermine, combination phentermine topiramate, naltrexone, bupiprone, liraglutide, semaglutide, and tirzepatide. We usually stick to the right two columns because they have revolutionized weight loss management. Basically, we should think about physiology first. Obesity is a chronic neurohormonal disease. Treatment must match the disease condition. Muscle matters. Weight loss is not equal to fat loss. You should preserve lean mass. We have increased protein intake, and resistance training is vital. We should manage expectations of patients, prepare them for the likelihood to regain weight, treat obesity like hypertension, not like an infection. That is to say, the treatment is going to be lifelong. Thank you for listening. More to follow.